Good morning. I'd like this to be somewhat informal. If you can't hear me, let me know, and if you have questions, let me know. I don't mind stopping the presentation. I'm not hooked on the slides or whatever. We could stop and talk and ask questions, and that would be fine with me. So in men's health, there are a lot of things that we can look at, and y'all have the opportunity to visit and listen to different presentations today. And they've asked me to speak a little bit about the more kind of, I guess, skittish part of men's health. And so what we thought we would do is present some information on erectile dysfunction and urinary incontinence. So what is erectile dysfunction, or ED, as many people know? It's basically the inability to maintain an erection adequate for sexual intercourse. Other names for it, obviously, is impotence, but the phrase ED has become real popular, and that's what we use. And how common is it? Well, 1 in 10 men in America will have some ED in their lifetime. So if you look at the statistics, over 30 million men in the United States will have problems with erectile dysfunction. In the past, it was thought to be more psychological, but more recently, obviously, we've found that it is not psychological. There's medical reasons for men to have problems with erections. What are the reasons? Well, there are a lot of reasons. Excuse me. In Louisiana, we have two of the top reasons, which would be diabetes and heart disease or hypertension. And so if you look across the board, those are two main things that we see in our practice that cause men to have problems with erections. In addition, men who've undergone different surgeries, including prostate surgery, but also colon surgery, pelvic surgery of any kind. There are certain medications that are more prone to giving patients problems with erections, including some of the blood pressure medicines, antihypertensive medicines, also some of the antidepressants. Also, the patients who have had spinal injuries, whether spinal cord injuries because of wrecks or gunshot wounds or whatnot. Also, we see problems in patients who have chronic back pain because they have problems with their disc, and those discs will impinge on the nerves. They supply information to the penis. So people who have chronic back pain or back issues are more prone to erectile dysfunction. And then there's some issues with hormone as well. So obviously the evaluation is started by the physician, your primary doctor, and then many times they'll refer you to a urologist such as myself. But there are set ways that we work with patients on evaluating you for erectile dysfunction. And once the evaluation is complete, then we move to the treatment algorithm, and fortunately we have a lot of treatment options at this time. The most common would be the oral medications, and obviously y'all have heard of the Viagras, the Cialis, Levitras, and things like that. But there's also other things like injection therapy, there's vacuum devices, there's penile implants. So I just put this slide together. These are the most common of the oral medicines that we can use, Viagra being the oldest. Sildenafil, but there's also the Cialis, which has a once-a-day preparation, Levitra, and now the newest is a drug called Stendra. Interesting, all these drugs have similar properties. They're from the same family, and they have similar type of chemical makeups. So they work similar. But some patients do better with one rather than the other, and so if you don't respond to one, you can always try another one. The other thing is that once you try one, if you're not successful initially, sometimes you need, you can try it again and you'll have better luck a second time or third time. So just because the initial time that you try to take one of these drugs you're not successful doesn't mean that you're not responding. And so I would encourage you to continue to try it and then work with your doctor if it is not successful. So what are some of the advantages of these pills? Well, obviously it's very easy to take, and most of these are effective. Almost 80% of these are work well to increase your erections. But there are some side effects that we do see in patients, and the most common are the headaches or the flushing feeling that you get when you take these drugs. Some people notice a little nose or runny nose type symptoms. Some people get a little nausea, but for the most part, they're well tolerated. The Viagra is one drug that's the oldest drug, but it has shown that it doesn't work as well with a full stomach and full meal. So we tell patients who are on Viagra to not take it with a full meal. You have to take it on either a light meal or an empty stomach. But there are also disadvantages, as with many things, good things and bad things. So the disadvantage is if you're on any kind of nitroglycerin, which is a drug that we use for patients who have heart disease, either the pills under the tongue, but there's also some oral pills, isosorbide, things like that, that are nitroglycerin class, then you should not take the oral medications. A lot of our patients worry that if they have heart disease, can they take these pills? And they can. They can take it safely. If there's any question in your mind, though, the best thing is to ask your cardiologist, your heart doctor. Of course, some of the disadvantages are the side effects that we just talked about. Well, you're right. That's a great question. The question was, what if you take, if one doesn't work, can you take a second one? Well, there are some certain top doses for all these drugs. So, and they're different. Viagra comes in the 50 and the 100 milligrams. The Cialis comes in the 2.5, 5, 10, and 20. And Levitra 10 and 20. Stendra is 100. So when you look at the numbers, it gets confusing because you say, well, I want to go with the higher number, the 100 milligram. Well, that doesn't, in the Cialis, there's not 100 milligram. The 20 milligram is the top dose, but that's very effective in a lot of men. But you shouldn't necessarily go over the maximum dose. Occasionally, and I think you need to talk to your doctor about that. If a patient is on the Cialis, which is and you're doing the once a day preparation, sometimes you can take an extra one before activity. But on the majority of patients, we recommend just staying on the dose that's recommended, obviously. There are also other types of treatment. One is a vacuum device. It's called a Recade, or there are a couple different companies that sell this, but basically it's using a cylinder that slips over the penis, and it's attached to a pump, and when you do the pump, you're able to form a vacuum. The vacuum causes the blood to fill up in the penis, and then you use these little bands at the base of the penis so that you can maintain an erection. Afterwards, you remove the band, and the erection goes away. And it works very well. It's obviously not any kind of medication, so you don't have any side effects from taking it. But it is somewhat cumbersome. You obviously need a very patient partner, and it is certainly a viable option for many people who do not want to take the medication. There's other treatment options. This looks pretty scary with a needle, but it works well also. The medicine we use is called prostaglandin, or alprostadil. It's a medicine that causes dilation of the blood vessels in the penis. And what we have to do is teach you to give yourself a shot. Well, it's a small shot. It's using an insulin needle, and a lot of patients do well. We find that many of our diabetic patients prefer this just because they're used to giving themselves shots with for diabetes control. Again, it has a good effectiveness up to 85%. There are some potential side effects. The prolonged erection sounds great, but it's really not. If you have any problem with prolonged erections over 2 to 3 hours, you need to contact your doctor right away. Using this type of drug, the alprostadil or prostaglandin, they've developed a little pellet. And the pellet is about the size of the end of your pen. And you can insert it inside the urethra, which is the urine tube. And this is not the pellet. The pellet is way down right here. And so you press this little button, and it deposits the pellet inside the urethra or the urinary channel. You keep the penis upright so that the pellet doesn't fall to the ground. And after a few minutes, the pellet dissolves. And it does the same thing. It increases the blood flow into the penis. It causes dilation of the blood vessels in the penis. And this works well. It's not quite as effective as the shots, but it's an alternative. It can cause some pain or discomfort, burning sensation in the penis, but it's certainly another option. If these type of treatments don't work, we still have other options. And the primary surgical option is a penile implant. This is something that is inserted surgically, and there are certainly a lot of patients who've had this. And there are different types and models and whatnot, but this is an example of a 3-piece device. The 3 pieces are the cylinders that you insert inside the penis. And there's a pump, which is inserted inside the scrotum, and there's a reservoir that's inserted up under the pubic bone. Once this is all placed surgically, there's no exposure. You don't have anything on the outside, nothing's external. The way it works is that the cylinders can fill up with fluid and cause an erection. Initially, they're not filled with fluid. When you're ready for action, so to speak, you pump the pump. The pump takes the fluid that's in the reservoir, circulates, and then fills the cylinders. And once the cylinders are filled, you're ready for action. And then afterwards, you press this little button right here, and it reverses the cycle so that the fluid goes back into the reservoir and the penis goes down. So it's a nice treatment, and it works well. It makes it feel like a firm erection, and it goes down quickly. There are certainly some potential side effects. Because it's a surgical procedure, you can have infection, malfunction of the pump device, but that's pretty rare. And so this gadget has worked well for a lot of people. And most of the men who we insert this in are very pleased because they don't have to worry about medications or devices or whatnot. Many times their partners are not really aware of it if they're able to get real good tactile sensation and able to pump it up without really fumbling around. But that does take a little bit of time and practice. No age restrictions at all. We do this, and again, because diabetics are a lot of patients that we see here in Baton Rouge, we implant these in diabetics who are very young, and they do real well. But we also have older gentlemen who we do it. And as long as you're, medically able to undergo a surgery, you can have this placed. It's usually done under either a spinal anesthesia or a general anesthesia. It's done in the operating room. Usually you go home either that day or the following day. And takes a while. It's obviously sore for about 2 to 4 weeks, but after the soreness wears off, it really is a nice option. It's dependable, it works well, it works almost every time. You just have to use practice, but of course it requires the surgery and there's risk of surgery. All of these things cost money and you have to get it approved by the insurance and whatnot. Once you've had an implant, if it does not work or if there's a malfunction or an infection, you have to replace it. You really can't go back to the other options, the oral medications or whatnot. So this is something that is, at this point, kind of one of the final tries at what we need to do. So in summary, with erections, it's a very common problem. Obviously, 1 in 10 men have some erectile dysfunction. And there are a lot of treatment options. We start usually with the easier things like the oral medications, but then if that's not successful, we have other things like the vacuum device, the injection therapy, the pellets, and then of course the penile implants. So I'll be happy to answer questions now. We have, I'm going to talk also about some urinary incontinence, which is leakage, but we could stop right here. Yes, sir.
What is the effectiveness of medications such as Viagra and Cialis for BP? They advertise for one of them that does take it for BP, as opposed to something that you would prescribe strictly for BP, such as Uroxetal. What is the effectiveness of these?
So Cialis, which is the one that has marketed as a once-a-day drug, is also been approved to treat BPH. BPH is enlargement of the prostate, and almost 80% of American men will have some BPH symptoms in their lifetime, which include slow stream, getting up at night, frequency, urgency, and things like that. Cialis has some studies that have worked well so that once-a-day Cialis does improve the urinary stream, does improve, lessen the frequency and the urgency in patients, and it's the only one right now that has been approved for both treatments, the BPH.
Just as good as the other ones that you do for just for BPH?
We just started doing that. That's a great question, and in the last 6 months we have had several patients who have used it. A patient yesterday I talked to said that he felt that the Cialis once a day has worked better than the Uroxetal, the Flomax, and other things. He was one of the few. A lot of the other patients have said they prefer to stay on those type of drugs, the alpha blockers, and supplement it with it. So if you're on one of those type of drugs and you decide to try the Cialis, you may not want to drop the first one. You may continue it. It's a great question, though. Yes, sir. The difference between incontinence and prostate? Frequent urination. Great. Well, we could go over to our next topic and we'll talk about that a little bit. Basically, what is urinary incontinence? Well, urinary incontinence is where you lose urine involuntarily. In other words, you wet on yourself without wanting to. And there are different types of urinary incontinence. There is stress incontinence where you leak either with coughing, sneezing, moving around, standing up. There's also urge incontinence where you have the need to get to the bathroom right away. You got that sudden urge and you have to get there quickly. And then the majority of patients have what we call mixed incontinence, which is a combination of both. Patients who have enlarged prostates who complain of slow stream and frequency will also tend to have more of the urge incontinence. And so that's a common thing for enlarged prostates. The ones that have had prostate surgery, either the removal of the entire prostate or the removal or the trimming of the prostate, may have more stress incontinence. So just kind of a general diagram, the bladder acts as a reservoir for the urine. It's a big muscle tube. And at the bottom of the bladder, at the base, is the prostate. And right beyond the base is a muscle called the sphincter. And what the sphincter does is it squeezes around the urethra, the urine tube, and it helps prevent urine from leaking out. And so in patients who have problems with incontinence, you can have problems with the sphincter. If the sphincter doesn't squeeze around the urethra, then urine will leak out. But you can also have issues with the bladder. And if the bladder is not able to fill completely because of the prostate causing you to have to push harder to get the urine out, the muscle of the bladder becomes thicker, and so you lose some of the elasticity, the distensibility of the bladder. So if you do that, patients tend to get more urgency, and you reach a point where you can't hold it anymore, and that's when you have that urge incontinence. Again, some of the causes for incontinence, this is primarily related to the stress incontinence, is the prostate surgery. You can also have spinal cord issues, people who've had spinal fusions, also spinal cord injuries, and then patients who have neurologic diseases such as Parkinsonism, multiple sclerosis, things like that. Again, you know, when you have these issues, the first thing to do is to report to your doctor and discuss it with him, and he'll do a workup, and he may refer you to a specialist such as a urologist. And then once the treatment, the evaluation is complete, then you have different options as far as treatment. This just goes over several of the treatment options. Some of the things that we see a lot, obviously, in South Louisiana is a lot of caffeine and alcohol, and many times I'll have patients who come in and say, I'm going to the bathroom a lot more frequently than I used to, getting up 4 or 5 times a night, and my first question is, how much caffeine do you drink? And they say, well, I don't drink very much, you know, not very much. I said, well, how much is not very much? And they tend to say, well, 8 to 10 cups of coffee a day. Well, that's a little bit much. The caffeine, iced tea, alcohol, they're diuretics. They're going to drive you to make more urine. And because you're making more urine, you have more chance of incontinence. And so one of the easiest things that you can do if you have some problems with incontinence is to cut back on the caffeine. Also, decreasing the fluid. If you tend to get up at night frequently, you may want to decrease the amount of liquids that you take after 7 or 8 o'clock at night. If you continue to have incontinence, the muscles, the sphincter muscles can be strengthened using exercises. Many of the exercises are called Kegel exercises, where you're able to tighten up those muscles. And nowadays we have some physical therapists who work with our patients on pelvic rehab, and basically what they do is they help tighten up those muscles in the pelvic floor and around the urethra, around the sphincter, and that does help with patients who have urinary incontinence. If a patient does not want to do that or continues to have problems, there are different pads that you can use. Obviously, women are more familiar than men, but these pads can help, especially if it's a minimal amount of leakage that you're experiencing. As far as medication, there are different medications that we use. Again, talking about stress incontinence, or the incontinence when you cough and sneeze, we sometimes will use 2 different types of medicine. One is Sudafed, which is the cold medicine. And what Sudafed does is it tightens up the muscles right around the bladder neck, around the opening of the bladder. And by tightening up those muscles, it helps prevent leakage. The problem is if you have an enlarged prostate, it may tighten it up too much, and if it tightens up too much, then you'll have trouble emptying your bladder at all. You'll go into retention. The other drug is tofranil, which is a good drug, which we don't understand exactly the way it works, but basically it relaxes the bladder. It also tightens up the muscles around the bladder neck. and it helps with urinary incontinence, the stress incontinence. As far as the urge incontinence, the patients who have problems with urgency or leakage when they have enlarged prostate, things like that, those patients respond well to two different types of medicine. One is they respond well with drugs that are used to treat enlargement of the prostate, such as the Uroxetrol or the Flomax, Proscar, or Avodart. Those drugs help either relax the prostate channel so that you can urinate easier, or they shrink the prostate. And by doing that, what happens, it allows the bladder muscle to not become so thick and have to push so hard to get the urine out, so it is able to relax and hold the urine longer. So we address those type of patients with the prostate medicines, or we also can address it with medicines that are used to relax the bladder. And those are what we call the overactive bladder medications, such as Detrol, Ditropan, Vesicare, and things like that. And sometimes we'll use a combination of those. So again, work with your doctor on that. Sir, I'm sorry. If it leaks out, right. Did I answer that? Okay. So if it leaks out, these are the treatments that we can do for the leakage. There's also devices. Again, they look kind of scary here, but this is called a Cunningham clamp. And it just squeezes the urethra, and it allows you to stay dry during the day. We recommend not using it 24 hours a day, but during the daytime, and then take it off at nighttime. It's obviously not a medication, so no real side effects, but it is somewhat cumbersome, bulky to use. Obviously, if things progress, we'll use catheters. Catheters are just tubes that drain the urine. In some patients, this is called a condom catheter or an external catheter. It works like a condom. You slip it over the penis. It has a little tube that attaches to a tube that drains into a bag. These are internal catheters that you insert inside the penis, and it drains the urine straight from the bladder into a bag as well. We prefer not to use these just because you do have increased risk of infection with these. But occasionally this is a nice way to maintain dry environment down below. So it's certainly an advantage. We have tried some surgical treatments, one being what we call a bulking agent, where we inject medicine into the wall of the urethra to try to close it or squeeze it, almost to make another prostate for you. If you've had prostate surgery, it kind of causes the walls of the urethra to close up. Unfortunately, we haven't really had much success, and so that really hasn't worked as well for our patients. The other two options for urinary incontinence, one is called a male sling. A sling is something that helps elevate things. So after your prostate surgery, especially after a surgery to remove the prostate, the urethra tends to fall in the pelvis, and so by re-supporting it, many men will obtain dryness with that. There's also a device called an artificial urinary sphincter, which is a device that kind of mimics that sphincter muscle by wrapping around the urethra. In patients who have a small amount of leakage, the male sling seems to be a very good option. However, for patients who have much more leakage issues, then we go with the sphincter. The sling itself is done as a surgical procedure, as an outpatient. Make an incision up under the scrotum, that's called the perineum, and you implant it, and afterwards you sew up the incision. You don't have anything exposed, nothing to fool with. Basically, it just pulls up the urethra, gets it into a better position and helps prevent leakage. So this is the sling right here, and it's made of a material called polypropylene, which is something that's synthetic, so it stays inside of you the rest of your life, and it really, for patients who have a mild amount of incontinence, this works real well. And again, mostly used in men who've had their prostate removed for prostate cancer. The sphincter, as I said, is a little bit different. It's a device. This is the sphincter right here. It wraps around the urethra, similar to what the sphincter muscle does inside of you right now. It's a 3-piece device, similar to what the penile prosthesis was. It has a reservoir. It has a little pump that is inserted into the scrotum. Nothing is exposed. So when a patient is, after he's healed from the surgery, this sphincter will close around the urethra and keep the urethra closed. And then when you're ready to void, to go to the bathroom, you press this part of the device right here. And what that does is it sends the fluid that is causing the closure of the urethra up back to the reservoir, and it collects in the reservoir. And it's really a neat device because after about 2 minutes, that fluid will automatically go reverse its and goes back into the sphincter, and then the sphincter will close on its own. So it stays closed with fluid in the sphincter. When you're ready to urinate, you press this button. It sends the fluid out of the sphincter, and then after 2 minutes, the fluid automatically goes back into the sphincter cuff, and it closes things off. So it's an interesting device, and it has been real well received, and it's successful. Patients do well, but it is a surgery, and there are certain potential complications, infection, malfunction of the device, but most people do very, very well. So kind of in summary of this, urinary incontinence in men is very common. And there are the 2 different types, the stress incontinence, which is related to leaking when you cough, sneeze, strain, most commonly in patients who've had prostate surgery or certain medications. And in those patients with stress incontinence, we do try medications a lot of times, and if the medications don't seem to work, we can go to the sling procedure or to the sphincter. There's also the urge incontinence, which is more related to enlargement of the prostate. In those patients, we try medications that work on the prostate itself, or sometimes we'll work on medicines that will relax the bladder to allow you to hold it a little bit longer. And those patients who don't respond to the medications and have enlarged prostate, then obviously another option is to open up the channel with surgery or trimming of the prostate. So there are a lot of options out there, and the best thing is to certainly ask your doctor. These 2 issues are common in men, and although it's not always comfortable to approach your doctor about it, there is help out there, so I encourage you to talk to your doctor and explain to him your symptoms or to her your symptoms, and there's certainly things that we can do to help with the condition. Some of these slides were given with, and we have the brochures that are out there. The company that we use a lot is American Medical Systems, and so I just want to give a shout out to them because they helped us with some of these slides and the brochures. But again, questions that y'all have? Yes, sir.
What has your experience been with medications that shrink the prostate? I know it's a long-term process. I was on one for 1 year and it didn't help. What has your experience been with those types of medications?
The 2 medications that are on the market right now is Proscar and Avodart. Proscar generic is finasteride, and you're right, it's a long-term proposition. really don't see any noticeable change in the urinary symptoms for about 6 months. And so you have to be on the medicine for about 6 months before you notice a change. But by shrinking the prostate, it does open up the channel, allows the urine to flow a little easier. There's some data recently that shows that in patients who have very large prostates, by taking these type of medicine, it reduces the chance of going the step further, which is the urinary retention, where you cannot void at all, and then you have to have a catheter and whatnot. So I think these drugs do help with that, but the problem is they don't work right away, and so you don't feel the benefit of them right away. There is one drug that kind of combines these type of drugs that shrink the prostate with the ones that help relax the prostate, and that's called Jalin. And what it does is it works to help relax the prostate, so you get symptoms of improvement early on, but it also shrinks the prostate. I think the finasteride, the Proscore, and the Avodart do work in some patients, but not always in everyone. So, yes, sir.
Like how the medical insurance companies look at erectile dysfunction as a recreational issue and not a medical issue, and they don't pay for the the oral or the Viagra or whatever. It's very expensive.
It is extremely expensive, and
Is it a medical problem or is it a recreational problem?
well, from a physician standpoint, I think it's a medical problem, and we've spent a lot of time on the phone with our different insurance companies trying to explain that. And it's interesting because I've had a couple patients who have worked for the insurance companies and have had these issues, and it's kind of, you say, well, you really need this medicine. I think it would make your life better, improve your how you look at life and enjoyment of life, and at the same time they understand that, but their own insurance company, their employer, doesn't pay for it.
Cialis with the dual benefits may be more of a possibility.
Right, except that sometimes right now we're dealing with the insurance companies will pay for Cialis for the erection, but not for the BPH. And so it's kind of strange. So we have to fiddle around, we have to talk to the insurance companies, but unfortunately these are expensive. Fortunately, many of the doctors here in town do have samples, and we can give samples out. Not today, but we can give them out in our office, and so, yes, sir. Yes, sir.
I don't dare to open it anymore without first going to the bathroom. Is there any solution to the problem?
Right. So that's an urge incontinence issue. He has to, every time he turns on the water fountain, he has the urge and the leakage. It's also called the key effect because women have the same sort of thing. When they put the key in the door after going to the grocery store, that's when they start to leak. But basically what happens is your bladder is a little bit hyperactive because it's having to push that urine out, and it loses that distensibility and that elasticity. And so by using some of the medications, I think that works well. The drugs that we use a lot of time would be the anticholinergic medications, which are the Detrol, Ditropan, Vesicares. There's a new drug that just came out within the last year that also works on the muscle of the bladder. It's called Mirbetriq, and it works a little different from all these other drugs, and it doesn't have the side effects of dry mouth and constipation that the other drugs may have. But again, in some patients such as yourself, it may be indicative of enlargement of the prostate, so we have to check the prostate out. So in some patients we do a combination again where we treat the prostate and we treat the bladder, and that sometimes works well for our patients. Yes, sir.
I was looking at TV the other day, and I seen on there that they had questions about Cialis, Viagra, saying that it may be causing cancer. Is there any truth to that?
No, no. It's a safe drug. People worry about it causing blindness, and that has not been proven. You have to have problems with your eyes long before that. I think the real concern is the taking these type of drugs with nitroglycerin. So.
I just seen it on TV, and they were saying that it was causing some kind of mammalian cancer or something.
Right, it has not been proven at all. Yes, sir.
For the urgent, when you have to go to the restroom right then, you had a couple of things on there, I think one of them, but I'm talking about over-the-counter stuff. Is there anything over-the-counter that can help alleviate this? You had Sudafed mentioned there on this.
Right, that's more for the stress incontinence, where you want to, when you have a cough or sneeze and you leak on you. The urgent incontinence, I think the biofeedback, what we sometimes will teach our patients is when you first get the urge to go, look at your watch and say, okay, I'm going to wait for about 2 minutes and then I'll go. And then the next week, I'm going to wait for about 4 minutes. What it does is it tries to relax that bladder muscle so it can hold more. Gives you a little bit more distensibility. But in men, again, the issue is that the bladder wall becomes thicker. It doesn't expand easily enough. And so right now, there's really not anything over-the-counter medication-wise that you can take. There is a patch that women use, and I guess that would be one option, and the patch just became available over the counter, Oxytrol. And that would be one option. But one thing you have to watch is if you relax the bladder too much and you have an enlarged prostate, again, you may notice that not only will you don't leak on yourself, but you may not be able to urinate because it relaxes the bladder too much. So you have to be, wary of potential side effects. Yes, sir.
Can you tell me about Flomax, and is there any studies on extended use with the side effects of Flomax?
Question is about Flomax. Flomax is tamsulosin. It's a drug called, in the category of alpha blockers. It's the one that relaxes the prostate, and it has been used for a long period of time, and I think it's works well. It does have side effects, obviously, that some people experience. It can lower your blood pressure a little bit. It can cause a runny nose. And some people, it doesn't relax it enough that you notice an improvement. But those type of drugs are out there. The ones that are selective for the prostate are the Uroxetrol, the Flomax, the Rapaflo. Those are the ones that work on the receptors primarily right around where the prostate lives. And it relaxes the prostate, relaxes the bladder neck so that the urine will flow easier. They're selective, of course, if they're newer. Flomax has been around, so there is a generic, which is nice. But the other ones, they don't always have generics. You can also use one that's not selective specifically for the prostate, and those are some of the medicines that we use for blood pressure control, such as Hitrin, Terazosin, or Cardura. And what they do is similar, is they relax the bladder neck, relax the area of the prostate, but they can also lower that blood pressure. But the long-term treatment with Flomax has been very good if you tolerate it and if it works well. The drug that I mentioned before, which is a combination of the ones that shrink the prostate and the ones that relax the prostate, combine the Flomax and the Avodart, and they combine it to one. Makes a lot of sense. Again, these drugs are good, but they don't work for everyone, and so you have to do some trial or error. Yes, sir.
I had a question, and I don't want to be redundant, but did you mention, because I was a little late, did you mention in your presentation on the procedure for going in and scraping back against the prostate? If you did, I'll watch it on.
No, that's fine. so the question was, what about trimming the prostate? Well, in patients who have the enlarged prostate, and we try to use the medicines such as Flomax, okay, to relax the bladder, relax the prostate, it works in a lot of men, and so it avoids having to do the next step, which you're alluding to, which is to trim the prostate. Trimming the prostate is where you go in surgically through the penis and you use different types of energy, either cautery energy or laser energy. And what you're doing is basically, if you think about it, the prostate is like a donut. And as the man gets older, that donut hole progressively gets smaller and smaller. And so to do surgery, you go in there and you actually trim out the inner part of the prostate, the inner part of the donut, to make the hole bigger so you could urinate easier. And so that's the classic term is the TURP, transurethral resection of the prostate. People call it the Roto-Rooter job. Nowadays, we use the vapor, the laser to do it, and it works very, very well. I'd say 90% of my patients, after we've done the procedure, ask me why didn't we do it 5 years ago, because it works well. It doesn't work right away as far as the urgency and the leakage that you have, but it does improve your flow. It lessens the amount of times you get up at night. And what happens over time is the bladder muscle is not having to work so hard to get the urine out, and so the bladder is able to relax a little bit, and so you're able to hold it longer. And so eventually it will help with the urge incontinence. There are other ways to do that. We were experimenting with using a microwave type of therapy, heat therapy. That was done in the office, and that just hasn't proven to be long-standing successful. So most of the physicians offer the resection or the laser treatment to help open up the prostate channel.
And would you have to go in at say years later and do the same thing again?
Many times, no. Occasionally, you can form scar tissue where you've done the treatment and you have to open up the scar tissue. But usually, once you've done the trimming of the prostate, over time, the prostate theoretically can grow back somewhat, but usually not enough that you have to do a second one. I wouldn't say that's a definite. I mean, there are some men we have to go back in and do some more additional treatment. But for the most part, the trimming the first time works well. Yes, sir.
I had read about a prostate massage. Apparently you do it yourself with a glove, hand, or finger. Is there any merit to that, do you think?
Yeah, prostate massage, basically, in men who have prostate inflammation or prostate enlargement, let me digress. The prostate does, what it does is it makes some of the secretions when you have sex. It makes some of the semen that comes out along with the seminal vesicles. And for some men, the prostate fills up with a lot of the fluid and it kind of gets what we call congested. And so by doing the prostate massage, it helps get rid of some of that fluid. It's not a comfortable procedure for the patient, and obviously not for the doctor either, but basically you put a finger into the rectum and you press real hard on the prostate, and it many times is pretty painful. But I have a few patients who feel like that does make them feel better over time, and it's mostly used for patients who have chronic prostatitis or prostadenia, which is inflammation of the prostate. Yes, sir.
This may be outside your department, but what about urgent bowel movements?
It is similar, urge bowel movements. It is a little bit out of my department, but it also, the one thing that we see is in patients who have problems with constipation will have problems with urinary problems as well. And so one of the things that you can do to help with urinary health is to make sure you have a regular bowel movement. And so we recommend taking Miralax or something like that on a repetitive, continual basis if you have problems such as that. If you don't empty the colon all the way, it pushes pressure on a sphincter, which is similar to the sphincter that's by the bladder, and it causes that certain urgency and urge to get to the restroom. So, yes, sir?
My father succumbed to prostate cancer. What are some of the things we can do to help eliminate or decrease our chances of developing prostate cancer, aside from getting your regular prostate exam?
Great question. So the question is, what can we do to help with maybe diagnosing prostate cancer early? And prostate cancer has been said that it's a kind of a slow-growing cancer. It's an indolent cancer, but in fact, it's the second leading cause of cancer deaths in American men. So it still is a lethal type of cancer. And so what we do generally is to do the exam, which is putting the finger into the rectum. That's the most common thing. But we also use the prostate blood test, the PSA, prostate-specific antigen. There's been a lot of talk about that the PSA isn't a very good a good test because it can be falsely elevated or it can be low. What we try to do is with each person, as a physician, we try to individualize each person. And so I still use the PSA. I think it's a good test. It's not something that I take one test and I say, okay, you're fine right now. What we do is we try to look at the PSA over a period of time. So I recommend going to your physician once a year, getting your PSA checked. For men who've had family members who've had prostate cancer, or actually African Americans as well, because there's a higher risk of prostate cancer or a higher risk of more aggressive prostate cancer, we recommend starting around 40 to 45. For some men who do not have that history, we recommend starting between 45 and 50. This is a little bit different from what the federal government has said. They said that they feel like the prostate cancer screening is not indicated. They used some of the data that they used was over some studies over a 7-year period of time. If you look at those same studies carried out to 15 years, it shows that there is some significant improvement in both diagnosis and treatment of prostate cancer. So I still think that the PSA blood test is a good type of screening. And again, it's not exact. Just because you have a high PSA number doesn't mean you have cancer, and just because you have a low one doesn't mean you don't have it. But you have to work with your doctor, and you have to see over a period of time.
Diet, exercise, and weight control help alleviate or minimize?
No one really understands what causes prostate cancer. There was an interesting study that looked at Japanese men versus American men, and the American men had much higher risk, higher incidence of prostate cancer, and the Japanese men, when they moved to the United States, their incidence increased. So the thought process is that our diet must increase our risk of prostate cancer. And so diet in high fats and things like that, I think, may increase your risk of prostate cancer. That's not definitely proven, but certainly being healthy, well, good, not overweight and things like that would be all helpful. But we really don't understand what causes it. But you're right to think that you need to have it checked early, and if you do develop prostate cancer, the thing is that nowadays that we do see more aggressive cancers in prostate, but we also see less aggressive prostate cancers. And depending on which one you have and what your PSA number is, and if you've had a biopsy, what the biopsy shows, then you could deal with how to treat it, or in some patients not to treat it, to monitor it. And so though some patients are diagnosed with prostate cancer, we don't always treat it. Sometimes we'll monitor it, what we call active surveillance. We follow the PSA numbers. Sometimes we'll repeat the biopsy. So it is important for all men to get their prostate checked, for sure. Way in the back.
What type of food should we eat?
I'm sorry? What type of?
Food should you eat for diet?
I think a low fat diet is good. There was some talk about vitamin E and selenium and zinc. Those really haven't been proven. There's also lecithin, which is a drug that is, a material that's in tomato products. And so if you like spaghetti, I think that would be good, just not too much spaghetti. But unfortunately, we don't have a proven thing that helps prevent prostate cancer. But I think a good, healthy diet is good. I think men who take multivitamins like a Centrum Silver, I think that wouldn't hurt. As far as the over-the-counter products, the beta prostate and all that, they have some of the drugs, the saw palmetto and things like that. At this point, there's not really a lot of good proof that those type of drugs help prostate symptoms. At the same time, men come into my office and say, yes, it does make me feel better. So we don't know if it's related to, what we call the placebo effect. So you're taking a medicine and it makes you feel better because you're taking something, or if it's really helping you. But so far, the scientific proof isn't there, but I don't think, I would say that I'm so arrogant that I feel like there's not some things that we just don't know in medicine. So, yes, sir. Great.
You answered it with the SARC.
Okay.
On that was my question.
Okay. Well, thank y'all for coming, and hope you have a good rest of the morning.